Hello everyone, welcome to this video on Airway Pressure Release Ventilation. My name is Mohan Prakash. I am an assistant professor from the Unit of Respiratory Therapy, Yenepoya School of Allied Health Sciences, Yenepoya deemed to be university. After watching this video, the viewers will be able to define the APRV mode of ventilation and its basic principles. You will be able to identify clinical scenarios where APRV is indicated and it's contraindicated. Viewers will be able to outline the steps to set and adjust key parameters. You will be able to recognize and troubleshoot potential complications that may arise when using this mode. You will be able to develop strategies to wean patients from APRV mode of ventilation as well. So first of all, let us learn what is APRV. APRV stands for Airway Pressure Release Ventilation. It's a mode of mechanical ventilation which provides two different levels of continuous positive airway pressure, and it allows spontaneous breathing at both of these levels when the patient has some spontaneous breathing efforts. Unlike other conventional modes of mechanical ventilation where only one level of positive airway pressure is given, that is positive end expiratory pressure, also known as PEEP, in this mode two levels of continuous positive airway pressures are given and the patient is able to spontaneously breathe at both of these levels. Coming to phase variables of this mode, it is time triggered, pressure limited and time cycled when the patient's efforts are absent. It also has several other names in different ventilator companies. So Drager, it's called as APRV itself. In Servo I, it's called as bivent. In Puritan Bennett, it's called as bilevel, although bilevel is entirely a different mode of ventilation. It shares some of the settings with the APRV, hence in Puritan Bennett, it's called as bilevel, although we can use it as APRV mode of ventilation. In Hamilton, it's called as DOPAP. So if you have to notice here, all these other names as well, they have some terminologies like bi or DO, which denotes nothing but there is two levels of pressures. Let us move on to clinical considerations. So when do you start a patient on this mode? That is nothing but indications. So primarily this mode is designed for some serious type 1 respiratory failure patients like acute respiratory distress syndrome, also diffuse pneumonia, patients who are at high risk of respiratory deterioration, and patients who have not responded to trial of positive pressure ventilation, and also patients who were trained on prone positioning ventilation but it was unsuccessful, or some of the patients who are not indicated for prone positioning ventilation, they can be started on this mode of ventilation. Moving on to contraindications, hemodynamically unstable patients. Since we are using high levels of pressure in this mode, it can further deteriorate the patient's hemodynamic stability. Hence, it's contraindicated. We are not advised to use this mode in these kinds of patients. Obstructive airway diseases, since it can worsen the air trapping, we are not using this mode in obstructive airway diseases. Recent pulmonary resection as well as untreated pneumothorax. Precautions. So what should be the precaution that you need to take before starting a patient on this mode? You have to make sure that the patient is not receiving any neuromuscular blockade agents or any sedative agents, because it will hinder the patient's spontaneous efforts and patient will not be able to spontaneously breathe. So we will learn in upcoming slides why is it important for the patient to have spontaneous breathing efforts. So what are the benefits of this mode? Why should we start patient on this mode when there is other modes available? So it will maximize your alveolar recruitment. So it's also one of the recruitment strategies in ARDS. So how does it happen? It prolongs the P high, that is one of the parameters that is present in these modes. So basically nothing but the higher pressure will be maintained for a longer period of time. So this will eventually increase your mean airway pressure. It will maintain the higher mean airway pressure throughout the cycle. So that will allow the time for the recruitment. It improves the patient comfort and patient ventilatory synchrony by allowing the patient to breathe spontaneously. It minimizes the need for heavy sedation. So in this graph, we are going to learn about how exactly this mode works. So if you see this graph, this is a pressure time graph. On the x-axis, the pressure is shown in in the y-axis, the pressure is shown in centimeter of water, and in the x-axis the time is shown in seconds. So if you notice here on the y-axis, there is some marks are there, that is P high is denoted, that is 30 centimeter of water, P low is marked, that is 0 centimeter of water. So these are nothing but the settings they have set in this specific case. And there is mean airway pressure also that is mentioned. This is measured, this is not set. So P high they have set at 30, P low they have set at 0. So these are the two levels of pressures that they have set. So how do we know for how long this higher pressure will be maintained? That will be based on this value, that is T high. So higher pressure, that is 30 centimeter of water pressure, will be maintained for this duration that is marked on this graph. That is nothing but in this graph they have kept a T high of 7 seconds, which is nothing but it indicates that pressure of 30 centimeter of water will be maintained for a duration of 7 seconds. So after that there is a something called as pressure release, or nothing but pressure will drop from higher pressure to lower pressure. So lower pressure in this case they have set at 0. So after 7 seconds of pressure being maintained at 30 centimeter of water, the pressure will be released, or it will drop from 30 centimeter of water to 0. That is specific to this case. We can set the pressure low of different values that we will learn in next slides. So after reaching 0, or after being released from the 30 centimeter of water, how long it should stay in 0, this level, how long it should stay, it will be determined by how much time we have set for the T low, this value. So T low will determine how long the pressure will remain at the P low. Here they have set approximately 0.8 seconds, after which the pressure will again rise back to P high. It will remain there for a period of 7 seconds. Again it will revert, or it will be reversed to the P low for a duration of 0.8 seconds. So that's how basically it works. And also if you were to see here, there are some movements which indicates that the patient is spontaneously breathing at the higher level. The patient has taken 3 breaths here. But if you were to notice at the P low, at the lower pressure level, there is no breaths, because this time is not enough for the patient to breathe. So if we are to give more time, the patient would be able to breathe even during the lower pressure, but that's not our aim when we want to release the pressure from higher pressure to lower pressure. The reason for releasing the pressure from higher pressure to lower pressure is mainly to eliminate carbon dioxide. So with the help of this slide, I will be explaining why is it important for a patient to have spontaneous breaths. If you were to see in the upper graph, so this is a graph of pressure time again. So this is a graph of a patient who is on pressure control mode of ventilation. Also at the same time he is receiving inverse ratio ventilation, which is nothing but for a patient who is on this mode, they will be receiving more inspiratory time when compared to that of lower exhalation time, which is nothing but patient will inhale for a longer period of time, they will have shorter duration for exhalation. So this is a one type of ventilation strategy. And here if you have to notice, this is the second graph which is of APRV mode, but in the absence of spontaneous breathing. And you see that there is no difference between these two graphs. In the pressure control inverse ratio ventilation, the patient, let's say here the patient has started inhalation, the pressure will rise, inhalation is sustained and the patient exhales for a short period of time, again patient inhales, the inhalation will go on, patient exhales. When you compare these two, the inhalation is for a longer period of time, exhalation is for a short period of time, and this will continue. If you were to compare that graph with the APRV, here also it's exactly the same, there is no difference in the absence of spontaneous ventilation. If the patient were to spontaneously breathe at higher levels, there will be some difference between these two modes, but here it's absent, so APRV will not work as it is intended if the patient doesn't breathe spontaneously. So how do we start a patient on this mode? What are the parameters that are available? When we were learning about the mechanics of the APRV, we have seen few of the parameters, but generally unlike other conventional modes of ventilation where we get to set the FiO2, tidal volume, PEEP or respiratory rate or any of such settings, inspiratory time, expiratory time, in this mode of ventilation majority of those settings are not available. Some of those are there, but the major parameters that are present are P high, P low, T high, T low and so on. So these are the major parameters, but how do you set them on basis of what physics or what physiology, how you are setting it, we will learn now. So first parameter that you are going to set here is the P high, which is nothing but the first pressure, also it's the highest pressure that you are setting. So it should be set no more than the 30 centimeter of water. But how do you set it? If the patient is currently on let's say assist control mode of ventilation, that is specifically volume control mode of ventilation, and you want to switch over to APRV, what you have to do here is you just have to give a inspiratory pause, then you will get a value that is measured, that is plateau pressure. So how much ever that plateau pressure is, you keep that as your P high. Let's say when you gave the inspiratory hold and the patient is on volume control and you observed a plateau pressure of 28 centimeter of water, you will keep that as your P high. But what if the patient is on pressure control mode of ventilation? Now we cannot measure the plateau pressure by using the inspiratory hold. Now we have to just keep the inspiratory pressure, whatever we had kept when the patient was on pressure control, that same inspiratory pressure will be kept as P high. Let's say the patient was previously on pressure control and you had kept the inspiratory pressure of 25 or 26, the same will be continued as your P high. Moving on to P low, how much do you set it? You usually set it from 0 to 5 centimeter of water, but majority of the times it will be set at 0. How do you set T high, or what is the T high? T high is nothing but the time for which the higher pressure or P high will be maintained. So this will be set somewhere around 3 to 6 seconds, ideally around 5 seconds you will start. Next is T low. So this will be set somewhere between 0.5 to 0.8 seconds, but how do you set? It's based on something called as your peak expiratory flow rate. So it should be around 75% of the peak expiratory flow rate. And how do you set T low based on the peak expiratory flow rate? You just have to follow a simple step. You have to start the patient on this mode. Ideally, initially you will start with the T low of 0.5 seconds. Then you will go to the ventilator graphics. You will check the flow time graph. You will see the patient's peak expiratory flow rate and how much ever that is. Let's say it's 40 liters per minute. You will have to calculate how much is the 75% of that. So 75% of the peak expiratory flow rate in this case is 30 liter per minute. So we just have to adjust T low such that your peak expiratory flow rate that will be achieved, or the expiratory flow rate achieved in your case will be 30 liter per minute, and it will not go beyond that. So in this case we might have to drop the T low from 0.5 to 0.4 or 0.35. That will be based on, that will go based on case to case. So why do we need to keep the T low to achieve or to stop the exhalation at the 75% of peak expiratory flow rate? This is important because we do not want the de-recruitment to happen. We want some air to remain in the lung, so which is nothing but it's called as auto PEEP. So we want to generate auto PEEP, thereby limiting the de-recruitment. So next, FiO2 we start with the 1, and based on your target saturation you can reduce it. Pressure support, this setting or this parameter is not available on all the ventilators in APRV mode of ventilation, but some of the ventilators will have this option of you being able to set the pressure support. If it's available, you can set it anywhere between 5 to 10 centimeter of water to reduce the work of breathing of the patient. Let's move on and learn about troubleshooting of the problems that may arise when you are using this mode of ventilation. The most common problem that you will face is hypoxemia. So how can you correct it? You correct or you increase the P high by 2 centimeter of water. If that doesn't work, increase the T high by 0.5 to 1 seconds. If it still doesn't work, you have reached the T high more than 10 seconds, you might want to consider reducing the T low by 0.2 seconds. All of these methods are unsuccessful, then only you will go ahead and increase the FiO2. Next common problem that is faced during mechanical ventilation with the APRV is hypercapnia. So how do you correct it? So you might not want to correct it. If the pH is greater than 7.25, you don't need to do anything, and this methodology or this technique is called as permissive hypercapnia. Even though CO2 levels are increasing, if the pH is above 7.25, you will accept it and you will continue to monitor the patient. But if the increase in CO2 affects the pH and pH were to drop below 7.25, then only you need to do some other steps. So what you do here is you ensure that the patient is spontaneously breathing. So that's your first method or first step. You will go and check the patient whether the patient is spontaneously breathing or not. If the patient is not spontaneously breathing, you should be able to see a graph which resembles when the patient is on pressure control inverse ratio ventilation, as we have discussed previously. So now if the patient is not spontaneously breathing, what you will do, you will check for the reasons. What could be the reason? One of the most common reason is the patient is sedated or patient is on neuromuscular blockade agents. Even though it's contraindicated, you might have started for some other reason, so you might want to stop that sedation or neuromuscular blockade agents. After this step, you will ensure that the automatic tube compensation, if available on that ventilator, is set to 100%. After all this, you will decrease the T high by 0.2 seconds to minimum of 3 seconds. Check the ventilator circuit and make sure that there are no obstructions or no leaks. Increase the P high to maximum recruitment and to reduce the dead space. Next problem that you might face is hypocapnia. So this is not that common, but you might still face it. What you will do, you will increase the T high by 0.2 seconds. If that doesn't work, you can go ahead and decrease the P high only if oxygenation is adequate or if it's excessive. Then you will reduce the P high. But because primary objective of putting a patient on APRV mode of ventilation is to optimize the oxygenation and not CO2. Moving on, if you see hypotension when the patient is on this mode, what you will do? This is mainly focused on medications or fluid administration. So we can administer a fluid bolus of 250 to 500 ml of crystalloids can be given. If that doesn't work, you can start the patient on vasoactive medications. If it still doesn't work, you might want to go ahead and do an echocardiography. So weaning, after starting a patient on APRV, you have learned how to set, how to titre the values you have learned, or how to troubleshoot you have learned. Now let us learn how to remove a patient from this mode of ventilation, or how to wean a patient from this mode of ventilation. The most common well-known method is drop and stretch method. So mainly you are going to control, or you are going to change two parameters. One parameter you are going to drop or you are going to decrease, the other parameter you are going to stretch or you are going to increase. What are those parameters? Let us learn. Before that, you might want to make sure that your FiO2 is below 0.5, and then only we'll go ahead with this drop and stretch method. After this, again you might want to make sure there is spontaneous breathing efforts by the patient, then you will go ahead with this drop and stretch. These two steps are very important before going ahead with this method. So how do you do the drop and stretch method? So which parameter you are going to drop? That is your P high. So P high you are going to drop by 1 to 2 centimeter of water. At the same time, simultaneously you are going to stretch the T high by 0.5 to 2 seconds. So how does it work? Let's say the patient is currently on the maximum possible P high, that's 30 centimeter of water, and T high is around 5 centimeter for 5 seconds. So now we want to do the drop and stretch method. So according to this, we will decrease the P high by 2 centimeter of water. Currently the patient is on 30 centimeter of water, we will reduce it to 28. Simultaneously we have to make changes to T high. It was 5 seconds, we will increase it to 2 seconds, and the same has to be continued every second hour. But until when? So until we reach the P high of 12 to 14 centimeter of water. We reduce the P high, or we drop the P high from 30 centimeter of water we had initially dropped to 28. Every second hour we will drop it by 2, 26, 24, 22 until it reaches 12 to 14 centimeter of water. At the same time, since we are increasing the T high from 5 to 7 seconds we had increased, we have to increase it every second hourly by 2 maybe. So then it will reach to 12 to 15 seconds. So after it has reached these target ranges, you will switch over the mode to your spontaneous ventilation mode, or pressure support mode of ventilation, it's also called as. In this mode, you are going to start a PEEP, higher PEEP you are going to target, that is around 10 to 12 centimeter of water you have to target, so that it will match the P high from the previous mode, the titered P high, not the initial P high. So here if you are to achieve the P high of 12 to 14 centimeter of water after weaning, in the spontaneous mode you are going to start a PEEP of around that 12 or 10 centimeter of water. The pressure support again is set to reduce the work of breathing and to gain a satisfactory tidal volume that can be set at around anywhere 5 to 10 centimeter of water. After this, after you start a patient on pressure support mode of ventilation, you will wean off this PEEP from 10, 8, 6, 5 or so on, and you will reduce the pressure support as well. You will make sure it's 0, then you will wean the patient from pressure support mode of ventilation and you will extubate the patient successfully. So that's all about APRV mode of ventilation. Let us summarize what we have learned in this video. APRV mode of ventilation uses 2 pressure levels supporting spontaneous breathing while providing mechanical ventilation to patient. This mode is primarily indicated for the patients with ARDS, and it enhances oxygenation, it improves the patient comfort, and it decreases the need for sedatives during ventilation. You may face some of the commonly known or commonly faced problems such as hypoxia, hypercapnia or hypotension, and it can be maintained by changing your pressures, various pressures that are available, P high and P low, and the times settings, T high and T low. If you were to change this, you should be able to effectively counter these problems. And also we have learned about a method to wean a patient who is on APRV, that is drop and stretch method. So where you will be dropping the P high and stretching the T high simultaneously until you reach a satisfactory target, and you switch over to pressure support mode of ventilation and you wean from there. But one thing you have to keep here in mind here is that you have to monitor the patient continuously. Every second only, once you have made a change, you have to monitor the patient. If there is any clinical deterioration, you might want to change the settings to that of how it was before, and then only we'll try slowly. These are the references. Thank you.